Okay, so thank you. That's a really fantastic overview. We're going to now move on to some more debates. The next session is really going to be around treatment versus, early intervention in terms of treating at biochemical progression or at clinical progression in patients with relapsing myeloma. I'm going to start with a case, and then we're going to do a vote. So this case is of a 60-year-old man who presented originally to his GP, to a spinal orthopedic team with thoracic back pain. MRI spine revealed a destructive lesion at T9 with a soft tissue component replacing most of the vertebral body and the right side of the pedicle, with a further area of replacement at T6. Baseline bloods revealed hemoglobin 127, renal impairment with a creatinine of 174, hypogammaglobulinemia, and very elevated free kappa light chains of over 8,000 milligrams per litre with a ratio of 6,000. Remainder of the staging revealed high beta-2M and an albumin of 50. Bone marrow confirmed the diagnosis of myeloma with 60% malignant phenotype plasma cells, but no evidence of high-risk FISH. And the CT chest, abdomen, and pelvis with skeletal survey confirmed the 2 known thoracic lesions, plus another small additional lytic lesion in the left humerus. So the patient was treated on the Myeloma 11 Plus trial with KCRD induction, achieved a complete response post-induction, and had an autologous stem cell transplant and remained in CR, and actually, a bit like the case earlier today, was randomized to no maintenance. 3 years later, he started to develop asymptomatic rise in the free kappa light chains. It's gone from 19 to 50 to 100 over a 6-month period with a lambda of 7, so a ratio of about 15, something like that. Had a repeat whole body MRI with no new lesions identified. And that just demonstrates a very dramatic initial early response, and then you can just start to see a slight creep towards the end. So in summary, this is a 60-year-old man presented originally with acute kidney injury and bony disease at diagnosis, with light chain disease, standard risk FISH, ISS3, achieved a CR post-induction, post-auto, and now has evidence of biochemical relapse, gradually rising serum-free light chains. Is now 3 years post-auto, not on any maintenance. So the questions we have for you now are: what are the best options to either start second-line treatment now? You would have already started treatment before we got to a ratio of more than 100, a difference of more than 100 rather. Repeat the bone marrow and genetics, or just close observation and serial re-imaging. So I think if you can get your devices out and answer one of those options, 1, 2, 3, or 4. Second line treatment now, you would have done it already. Repeat the marrow and genetics, close observation, and repeat imaging. Just give it another 5 or 10 seconds. Okay, let's see what that shows. Okay. So there we go. So already over 50% have suggested just close observation and serial re-imaging. About a third have repeating the marrow, undertaking repeat FISH to see if there's any clonal evolution, and then about a sixth will start treatment now, and very few would have actually already started treatment at this stage. So let's see what influence next 2 speakers have. I'm going to introduce both speakers now so we can go back to back. So first of all is going to be Charlotte Paulin, who is a CRUK scientist that I'm sure you'll know very well, working at the ICR and a consultant hematologist at the Royal Marsden. She leads the myeloma biology and therapeutics team there at the ICR, focusing on new therapeutic targets to improve outcomes, including IMiD resistance and high-risk disease. She's also very actively involved in a number of myeloma studies in terms of being a member of the TMGs, as well as being closely involved with myeloma 11, myeloma 14, and is actively designing, as you've heard this morning, on the IFIT, which is the new frontline elderly study. And then followed by Charlotte. So Charlotte will be talking about treating early, and Emma will be giving the opposing argument. So Emma trained in Manchester, also along the way gained an MA in medical ethics and cancer and palliative care, and has also been awarded the CR UK PhD fellowship, which she completed in 2016. She's now a consultant haematologist at the Christie in Manchester, with a particular interest in early phase clinical trials of a range of novel anti-cancer drugs, so actually not just in myeloma but also in AML, and is actively involved in a number of early phase studies. She's also the Deputy Chair of the Experimental Cancer Medicine Centre Network Group, Deputy Chair of the BSH Research and Grants Committee, and a member of the AML and the Steering Group and the UK MRA as well. And she was also awarded an Early Career Researcher Award in 2023. So over to you, Charlotte, first of all.